everybody's talked about being rhythmic and everything has to be in a proper balance and all those things. I said, you know what? Let me just talk about how I see hormones being prescribed in the United States. So my presentation is based on not what I do, but what you guys do. So what I'm presenting today is I work with over 1,000 physicians all over the United States. We have filled over 250,000 prescriptions in my pharmacy for the last 20 years. And we work with about 9 or 10 compounding pharmacies in my pharmacy. And we meet once a month and we gather data and see what doctors are prescribing, but more importantly, what patients are buying over and over again. Is that what you guys want to know more about it, right? Because you guys are in a solo practice in somewhere in a mountain, and you have no idea what the guy down the street is doing or the guy across the country is doing. And so what I have done over the years is I've compiled the data, so much data that it tells us what's working, what's not working. And I'll be the first guy to tell you if a commercial medication is working, it will be on that list. If the FDA-approved medications are working, it will be on that list. Because I am not married to a particular product. What I'm married to is my patients' safety and their efficacy in their treatment. So what you're going to see today is this is where it's going to go at. So where it started from, my journey, it was 1999 when I read Dr. Katrina Dalton's book. This was just published in 1999. And I don't know if you know her, but she was the one who basically introduced progesterone to us back in the early 50s. So now we are going back 70 years now, and I understand the therapy in this book is barbaric. I don't want anybody to go through that therapy that's in this book, because I've tried about quite a few patients, probably over a dozen patients, and what they did not see in this book, what we see today, is systemic candida by prescribing too much progesterones. So if you use the protocols in this book, you're guaranteed to have systemic candida. I have patients on those at those dosages. I have candida issues on those patients. And we just lost one patient because of overdose on progesterone. So if you think progesterone is safe, think twice. So that's about it. You've seen a slide from Dr. Evans. So I'm going to skip that slide because you're done looking at cycles. So when you talk about PMS, there's PMS, PMDD, perimenopause. I kind of bunch them together, so to speak, because it's a giant thing. Don't copy this thing down because this is just a placeholder. I'm going to go with the protocols again at the end. So you have choices of prescribing hormone replacement therapy with bioidentical hormones. You're prescribing commercially approved medications that are approved by FDA, like we have approved Seraphim as an antidepressant, fluoxetine for PMS. So, I mean, we have approved all these medications for you guys to use it for patients with symptomatic relief, but that's about it. It's all about symptomatic relief, and we're not actually going after the cause of the problem. And of course, you have an option of doing surgeries. So, Dr. Evans just mentioned to a 20-year-old girl having a surgery because they had a BRCA genes, and I mean, it's sad that, I mean, it could be indicated, could not be indicated, we don't know, but I mean, the whole life to go without ovaries and have a double mastectomy done, I cannot comprehend that. If I say that I'm going to have prostate cancer in the future, do I take my prostate out today? I'm not sure. I don't know what I would think about it, but again, surgery is an option. It's not recommended, of course, because it's irreversible. That was something that was given to me. Anyways, so PMS. What are we doing in PMS treatments? It's basically, we are correcting estrogen dominance with some progesterone therapy. Now, is progesterone the only answer for PMS? It works. I'm not telling you it doesn't work. It does work. But they may not be the only answer. And so I had to give you some other options that may be working. If you go down the list of all the vitamins, what are we treating? Stress. So, I mean, think about it. It's all about stress-induced hormonal deficiency, and we are giving them zinc for excessive stress or having aromatase enzyme activity going at a very fast pace because of low zinc. B complexes because we are burning a lot of B vitamins when you're highly stressed, C's and magnesiums and vitamin E, and B6 to have a neuroplasticity. I mean, Jim loves vitamin B6 in his all his regimen because of giving the neurons some neuroplasticity. But again, these are all adjunct therapies. All we're trying to do is support what the patients are going through right now, other than just getting rid of the stressors. And think about a PMS person. It's probably a 20, 25-year-old person that is going through probably the best time of their life and the worst time of their life at the same time. And they don't know how to handle those situations. Eating a plant-based diet, that's why when Jim said this morning about going vegan, I was in the back laughing because he's a carnivore, I'm a vegan myself. And we always have this beef against each other. I said, well, I look this small because I eat less, and you look this big because you eat healthy. But at the end of the day, it's who are the better neurons. I think he beat me on that one too, but that's okay. So plant-based diet can absolutely help you reduce the stress. Eating fish, and it's not about the fish and the proteins, it's about the oils. But you do have to worry about the mercury contents, and thanks to the glutathione now, we can get rid of the mercury if we have to. A lot of other oils, evening primrose oils, borage oil, flaxseed oils, those are going to be very good. The Valdem extracts, Vitex, Disoras, and there's a lot of the options that support, all these things supporting what? If you think about it, they are all supporting neuroplasticity. They're all supporting to have a better cognitive functions for us. It's not actually doing anything for the PMS per se. But so all this adjunct therapy are good to have, because when you say one drug cures all, it sort of becomes panacea. People don't believe in it. But when you give an options of different things they can do, then everybody does deliver things differently. So we want to give them more and more options as much as possible. And one thing that I cannot make anybody do today, we have all the technology in my pocket, on my wrist. I don't have the wristwatch, but everybody has so much technology. I just ask them simple things. Can you record what you did every single day? And he goes, oh my God, I can't do that. I said, you can just speak in your watch and they'll record it for you. And there's a diary that you can do that for me. You know what they're afraid of? Accountability. That's what they're afraid of. They don't want you to find out what they're going through. They don't want you to know what they're eating. They don't want you to know how much they exercise or how much they're sleeping or whatever. So it's not about PMS. It's are they going to be accountable for their own health? And until I put them the responsibility in their hands, I said, hey, you own this problem. They're not going to fix it for us. I can give all the medications in the world, but until they recognize their own problem, they're not going to fix it. So what's a typical prescription I see all the time? What works? Now, Dr. Dalton's protocols, I'll show you that as well. But this is what I see all the time. Topical progesterone. I don't see oral progesterones in here at all. For PMS, most of the time, topical progesterone works the best. And I've marked it a pretty good presentation during the lunchtime, that when you apply topical progesterone, it is bound to the tissues. It is not going all over the body. So typically, when we see the progesterone prescriptions, they apply on the lower abdomen, inner thighs, as close to ovaries as possible, and we have the best results. And all we're trying to do is saturate the lytic cells. So at this dosages, we are getting the best results for the PMS. Do I see prescriptions for 200 milligrams per gram and 400 milligrams per gram and so forth? Absolutely. This is what they end up at the end of the day, and this probably at the dosage works good. Now, one thing I'll tell you is about the PMS type treatments. Is it long-term treatment, short-term treatment, forever treatment? And it all depends on person. The younger the person, it's extremely short-term treatment. I have patients that come to us when they are in the 13, 14-year-old age, very, very young. They take the progesterone treatment for maybe about 3-4 months, and they're off of them for at least 5 to 6 or 10 years plus sometimes. You get the patients in the early 20s, 25s, they'll probably be on the treatment for about 8 to 9 months, and they're off the treatments for a pretty long time. Once I get the patients over the age of 30, 35, again, it's changing. It used to be 40 plus, it's getting down to 30 plus now. They generally tend to be there for longer periods of time. And sometimes they get into perimenopause, and then they are pretty much there forever. But so just keep in mind, this is not a long-term treatment, and try to get people off the progesterone as much as possible, because as much as they're good for the patients, I do believe progesterone can cause gut candida, systemic candida, as I've seen it plenty of times, that I'm scared to give anybody more than what's necessary. You heard about PCOS from Dr. Gersh plenty of times, but again, with the PCOS, it's not just progesterone or hormone imbalances. There's multifactorial problem that she was discussing about. And again, you have some additional drugs that's available. I love berberine to really help with insulin resistance. So if you're not a big fan of metformin or glucophage, there's an option available for you. I know Jim was talking about metformin causes oxidative stress. Anyways, you have another choice of berberine over the counter, herbal supplements, things like that. I'm sorry, a shameless plug, glutathione. I didn't mean to put this one inside at all. This is my personal studies. It's not supposed to be here. We have seen tremendous results with reducing triglycerides with topical glutathione. It's not published yet. That's why I cannot speak about it. This is my personal slides, and I didn't want to push it out there. So. Anyways, other thing that I've seen a lot of is when we see PCOS patients, we see heavy bleedings because they have cycles every 3-4 months, and there's very heavy bleeding. It's hard to find all the medications today because all the steroid compounders are getting out of business, and it's been very, very difficult. Folinic acid with P5P, with the B12s, combine them together. This is an excellent medication that we have. One of the physicians in Texas gave me the formula to do it. And ever since I've been using this formula for all my patients, and we reduce homocysteine levels, we reduce CRP levels, the inflammatory marker goes down, IL-6 goes down, IL-2 goes up. This is a fantastic formula. The folinic acid, which is leucovorin, is in short supply today. It's not available today, so that's the bad part. Hydroxycobalamin is available, plenty of them. P5P is compounded for you. Methylcobalamin is also compounded. If it's not available, you can always substitute with just hydroxycobalamin. So, combine them if you can, and use them for your patients, because this thing really helps them with the blood flow and making them feel better about that. Anyways, when you do give high dose of progesterones, especially if you're going to start giving 4 milligram suppositories, the highest dose I have given, which is in the book, which was 4 milligram suppositories, 2 of them TID. 2.4 grams per day to control PMS type symptoms. It was more like PMDD. The 3 girls I had, they were all in the institution. They were on antidepressants and antipsychotics. They were on 24 hours surveillance. And the doctor prescribed these medications. 6 months later, they were all discharged from the hospital. They're fully functional human beings today. It's been almost 19 years. So it does work, but the problem is the doctor forgot to take the dose down on one of the patients. That one patient has severe candida and bloating, and it's just unfortunate. Because of that very reason, all the progesterone that we produce today has Saccharomyces boulardii built into it. Because I don't want any of my patients to ever feel bloated or any of them having any candida issues. So all my oral progesterones have Saccharomyces boulardii built into it. If they don't prefer to have it from me, they can buy over the counter. It doesn't really matter. I just want them to have something to make sure that they have some protection against fungal growth. You've been beat down too much on that one. All right. Managing perimenopausal goals. Okay. Dr. Evans said very clearly to us, when they're in perimenopause, you pray to God, right? Because it's just hard. the best thing we can do is educate these patients. We want to educate them because we can only see 10, 20 patients a day. If you're a super person, then you're probably seeing 30 patients a day, which I don't see too many over here, because if you're seeing 30 patients a day, you can't be here today. But the way we can only see 10 patients a day is if we educate our patients to take care of themselves for minor things. And we only deal with the major things. So patient education is the biggest thing, and if you don't educate your patients about what to do when things go south, we fail them to, because then they will calling us on a daily basis. Maybe not you, but pharmacy is easily accessible, right? They pick up the phone and call the pharmacy, and we get calls all day long from patients. And we just call the doctor. Oh, shucks, I left a message for her 2 days ago. She hasn't called me back yet, or he hasn't called me back yet. So we get called all the time. So educating patients is the #1 goal when it comes to perimenopausal time, because once they know better, we have better chance of getting them under control. Second thing is prevention of cancers. The third thing is symptomatic relief. That's the best we can do with perimenopausal. We are not going to advance them into menopause. We're not going to keep them into perimenopause for long periods of time. I mean, what's the goal? When patient is in perimenopause, do we want to force them into menopause as fast as possible? Do we want to keep them in perimenopausal and somewhat balanced? You know, so it's very tricky. It's very tricky. And the best we can do is educate them as what they're going through right now and just hang in there, you know. And we'll do our best to be there with them. The hormones that you're going to use at your disposals, these are all the hormones, right? You're talking about estriol, estradiol, testosterone, DHA, pregnenolones, cortisols, thyroids, insulins, some herbs, some supplements, and vitamins, and there's a whole list. Dr. Evans said to us earlier, in perimenopause time, what you're going to give them? One hormone, mostly just progesterone. That's what you're going to give most of the time, because perimenopause time, the FSH is rising, the LH is rising, they have estrogen dominance, the sex hormone binding globulins also rising. Testosterone levels are normal, but they are bound by sex hormone binding globulins, so they may have symptoms of low testosterone or low estrogens, but they're all protein bound. As soon as you give them progesterones, the sex hormone starts dropping and everything becomes available to you. So do not go by a lot of symptoms. You probably want to do some testings to figure out, you know, what exactly is there. But more than likely, it's just the progesterone is what you're going to need. Now the question is do you give them daily or rhythmic? So you heard the story just about 5 minutes ago. I like to give daily, right? I like to give rhythmic. Okay, that's my philosophy. Why? We've been learning all day today that we want to do balanced life. We want to have something that our body is used to. It's something that we're accustomed to. We are not accustomed to producing daily hormones throughout the day, all the time, the same levels. We go up, we go down, we go up and go down. It's like what Jim said in the first slide early in the morning. The estrogen goes up and goes down and goes up and goes down. Diurnal variations is what we need. So in that very reason, we want to give rhythmic hormones. What's going to happen to patient compliance? You guys don't deal with patient compliance, right? We get paid based on if the patient takes the medications or not. We don't get paid for giving the medications. We get paid for if they take it or not. So for us, is we got to figure out how can I get these patients in a proper balance and at the same time take it exactly the way the doctor prescribed. It's a very tricky situation, but there's two trains of thought about giving daily or rhythmic. But the choices you have is capsules, troches, and tablets, and mucosal gels, and transdermal gels, and suppositories, and IM injections, and then what you have, pellets, and all sorts. So I'll just go briefly over this pharmaceutical side part so that you're aware of it. So capsules, swallowed by mouth, causes, if it's a progesterone, causes drowsiness. It's a huge first pass effect. That's why progesterone topically, when you give them, doesn't go systemic. It doesn't have a huge first pass effect. You don't get drowsy from taking topical creams of progesterones. Suppositories is excellent if you're giving very high dose of hormones. Other than that, it's very cumbersome. It's not generally well tolerated by the patients. They don't like that much. Regardless if it's vaginally or rectally, it doesn't really matter. Sublingual drops, tablets, and troches are absolutely the best for Americans because they are pill poppers. We love to pop a pill, right? If you give me something by mouth, I'll take it today. If I did it all slapping your wrist and go like this, or rub it over here, or rub it over there, come on. Now that's European, by the way. They love creams, and we have pills. So there's a differences. But again, in theory, if you take sublingual hormones, in theory, it's the best, right? Because you're going through transmucosal membranes, you're not having the huge first pass effect. It's the best thing in theory. In practicality, the absorption is very poor, and you end up swallowing all the capsules and the tablets and the troches and everything else. And what ends up happening is that you have a huge first pass effect, your liver gets taxed, and all of a sudden you have other issues to deal with the oxidized hormones and metabolites. IM injections, again, they were great back in the 50s because there was nothing else available. Today, we got plenty of choices. I haven't seen the strips for at least 15 years now. So I don't see much on the IM, except for testosterone. I see this still for some of the guys that want to look, So I do see them once in a while. Pellets, again, pellets, like Dr. Evans said just earlier, there's no clear evidence of any bad things with pellets. But the only thing that I always think about it is pellets is that what? You have a continuous dose of hormones coming to your body day in, day out for the next 6 months. There's no ups and downs, So my personal bias, and I stopped making pellets about 10 years ago when I first heard about this thing. I was making a lot of money making pellets for doctors all over the United States, and I stopped doing just because I don't think it was the right therapy for my patients at that time. So we just decided not to make pellets. Topical creams, okay, creams are crazy now. Creams are going to get you wild. You have topical creams, you have transdermal creams, trimucosal creams, you have liposomal-based creams, and they will tell you all kinds of stories about cream bases, right? You can put everything into 3 buckets, okay? You have gels, which are typically alcohol-based gels or water-based gels. Guess what? All hormones are steroids. They don't dissolve in water. Useless. Gone. Right? The second gel, which is an alcohol-based gel, is probably good because alcohol as a solvent can dissolve the hormones, and that's how it transports your hormones. Alcohol-based gels are great for guys because guys have thick skin. They don't dry up easily. For girls, guess what? Alcohol-based gel will dry your skin up like crazy. And now you cannot use a cream. So most of my female patients do not prefer to use an alcohol-based gel, like estrogel that's commercially available, or the Evamist. There's so many. All the commercially available products are all alcohol-based gels, unfortunately. And then you have transdermal gels. Transdermal creams or gels or whatever they are, they're basically physically forcing the medication through your skin, disrupting your skin physiology and going the medication through your skin. So those are pretty much liposomal-based products where what it does, it mimics your lipid membrane and it basically forces the medication through your skin. Much more predictable results. So you can predict how much medication is going to go through that. But the other thing that the transdermal gels does for us, you can deliver a lot more hormones this way. So typically, let's see, if it's a cream base, cream is at the maximum you're going to have is 30% oil in a cream, maximum. Okay, the heaviest cream that you can buy has a 30% oil. So if you look at solubility of hormones, you can only solubilize maybe about 200 to 300 milligrams of any hormones per ml. So if you're going to use a topical cream, maximum you can ever going to solubilize that hormones in that oil phase is about 100 milligrams. That's if the temperature is right? There's no temperature in the pharmacy. It's a cold process. So at best, you're going to absorb a little bit less than 100 milligrams. So when you kind of only going to deliver that much hormones per ml of cream, and if you have to give 200 milligrams, what do? you go to transdermal in the liposomal-based products. So that's the reason for these different types of products. Again, I don't want you to remember anything. I just want you to know that when pharmacy is designing a products for you guys with different bases, this is the thought process that goes into their mind and how we design the products. Yep, alcohol-based, yes, we just talked about that one. Fast absorbing. The good thing about gels, they really absorb really, really fast. So when you're taking alcohol-based products, it's a great, even for female patients, they do like the product. It's just that they have to use a moisturizer after that. The only downside is that a lot of the best application site for most of the hormones is label applications or perineum area for the guys. And those tissues, you put alcohol in there, and I can see the bullet coming on my head the next time I see them. So we don't see a lot of scripts for those, but we do see once in a while like those things too. So now this is the one we're talking about, right? Typical prescriptions. Let's see how much time I got. Okay. Typical prescription I see in perimenopause time. Now, Saccharomyces boulardii, I always add that with my progesterone capsules, but I only use capsules if the patients have symptoms of insomnia, which typically they do have something of an issue. And if I can tackle that with some theanine and melatonin, then my preference is to give them topical progesterone. It is localized, there's no systemic absorptions, it gets the job done for us. You know, I get better results with topical progesterones than with oral progesterones for that very reason. Estrogens, there is no need for estrogens in perimenopause times. If I ever have to give them estrogens, I do not see anything more than 0.625 milligrams, at the most 1.25 milligrams of biestrogen, which is 80% of estriol, 20% of estradiol, which equates to about 0.025 milligrams. It's a very, very low dose of estrogens of estradiol in there. Again, we're only doing for symptomatic relief, so we're not doing for anything more than symptomatic relief. Androgens, I hardly see androgen prescriptions, even though they have decrease in sex drive, or they have osteoporosis, or they have symptoms of low androgens. We still go with the progesterone therapy first, see how they behave. In 3 months later, if they still need the other hormones, we'll add them as needed. Typically, they will not need them at all. But when it comes to menopause, they get the whole thing. Now, we always prescribe Bias, and again, Bias is not a commercially available product. Why do we always give estradiol and estriol combination? We just heard about the receptor sites are different. If you apply on the breast tissue, it stays in the breast tissue. If you apply on the inner thighs, it stays in the inner thighs areas, things like that. But when it comes to the estrogen replacement, we always ask them to apply to the inner labia. I always put milligrams and daily. I didn't put the application sites because everybody has different application sites. So who over here prescribes on the wrist? Inner arms, inner thighs, outer thighs, lower abdomens. You know, you see, people prescribe all over the place. So until 2009, I was in the same boat as you are. People prescribe anywhere. I fill the prescriptions and let them go. And my business goes up and down, up and down. I said, my God, what's going on? I lose my patients all day long. I get new patients, and they don't work, and then I lose them. So in 2009, Dr. Jonathan Wright came to my pharmacy, and we had a presentations for a bunch of physicians, and he said, why don't you try inner label applications? That's what I've been doing for 20 plus years. So, geez, I can't know. So I had one barbaric doctor says, I'll do it. I said, good, we'll try it. Since then, my whole practice has shifted to inner label, application to the inner labia. If it's a biased or testosterone or DHA, if it's a small molecule, small volume, I will drive it through the mucosal membranes. And if I do that, I never have to worry about receptor site sensitivities. I don't have to worry about absorption issues. I don't have to worry about cross-contamination unless it's in the evenings, but then I always work with my female patients to when to apply it. Anyways, so it's the application sites makes it a big difference, and if I do that, I can get away with low dosages. Just to let you know, my highest dose in my pharmacy is 2.5 milligrams of bias, which is half a milligrams of estradiol, just half a milligram. And so it's very, very low in terms of how much medications you'll actually need to get the job done. And I'm a big proponent of low dosages because Jim said early this morning, right? It was so, I was listening in the back and said, oh my God, this is going to fit right into my lecture because everybody that you talk about wants to give a lot of hormones because they want to get you to youthful age. We can't get to youthful age of hormones. We cannot. We don't have the body, the capacity, or the enzymes and everything else built into it to process all these hormones. So what hormones we need is how much we can process. So this typical dosage works great for the patients. I have great symptomatic reliefs, and this is what get refills all the time. I do get scripts once in a while for a little bit higher doses than that, and I generally lose those patients because now they have some symptoms of too much of estrogens. Now, this is the only time you're going to see the greater or more to the age because menopause is not age dependent, unfortunately, but this is one of my OBGYN practitioners in my area told us, this is what she does. If it's less than 45 years of age, she gets birth control. If it's more than 45 years of age, she gets Premarin. That's it. That's what we did. But so in menopause, what we do is a little different now. Now, we always stems off the estrogens. Now, if it's menopause, early onset menopause, like you just found them out, low dose estrogens is going to be enough because they just jumping off the cliff right now. They're not all the way to the bottom yet, you know. So low dose estrogens are plenty. I always give cyclic, so they go from day 1 to day 21 of the day of the month or of the cycle if they're still cycling. No, they're not cycling, but they just came off the cycle. So we do from day 1 to day 21, or progesterone from day 30 to day 27. Now, most of the patients are not going to do that. They can't remember that. They have apps for that. They just cannot do it. So this is pretty much a standard to go to, and it ends up failing most of the time. So if you're going to try it, you can try it for 1 or 2 months, and the patient's going to lose. You can lose the patients, and then you can go back to the old form, which is going to be giving them daily hormones of pretty much from day 1 to day 25 of the estrogens, and I usually give day 6 to day 30 of progesterone. So my cyclic way of giving hormones is I give first 5 days off of progesterones and last 5 days off of estrogens. And so it's not the best, but that seems to be the best for the patients that can remember. Because keep in mind, we have to figure out what they're going to actually do versus what is right for them. You know, what's right for them, if they're not going to do it, it's useless. So I got to figure out the balance between what is right for them versus what they're actually going to do. So that's what we do. Testosterones, I don't give more than 1 milligram to anybody. I cannot remember anybody more than 1 milligram for a long time. I get it once in a while, 1.5 to 2 milligram cream for testosterones, and within a month and a half, they will come back down to 1 milligram because it's too much for them. So typically half to 1 milligram. Again, this is all to the inner labia applications, and we have the small devices which is just like a dot. You just apply it, it just absorbs it like in literally 30 seconds. When we give DHEA and pregnenolones, we always give as a combination if you're giving them orally. As an oral combination, you can get away with low dosages because they both work synergistically orally when you combine them. So I can get away with 5 and 10 milligrams of DHEA if I'm giving them 25 milligrams of pregnenolones with it. So that's what I typically see a lot of scripts for it. But if the patients have aches and pains all over the body, we see topical applications of the same hormone. So if you give topically, you see the aches and pains goes away. If you give orally, it helps with memory and cognition. So if they have both problems, what do you do? Eventually, it will work for both of them. It just takes which one do you want to work faster. So if I always like to give capsules because if I have my brain power, I can think better, I can make better choices next time. So I always try to give them oral pregnenolone DHEA, but absolute topical is another choice if they have aches and pains over the body too. So these are typically what we see in my practice at all times. Now it is not very fancy. It is not something out of ordinary, but you have to know that 80% of the population is not out of ordinary. They're just you and me. They're very simple people, okay? So I know this whole day has been, I can't imagine you're still awake right now, but this whole day you've been given so much information about what to do when things are, what to look for it. But keep in mind that 80% of the population, you don't need all this information. It's basic stuff. But the 20% of the population, which consumes 80% of your life, you need to know all those things about, right? So my job is, can we just attack 80% of the population that comes to you for basic needs with basic prescriptions, get it out of the way, so now we are focusing on this 20% of the population that is consuming your whole life for you. So that's what we are all about, all right? So all we're talking about is that, we want to make sure that when you are giving them hormones, is you take into account all the things that you have to worry about. We didn't talk about cortisols and insulins and thyroids and all those things, but you've been beat down this whole path all day today, so I didn't want to mention any of those things. But until you fix the cortisol, none of my therapy is going to work for you guys, none. So fix your cortisols, fix your thyroid, fix your insulin, your gut, and then you come back to the hormones. Why do I get the best result with low-dose hormones? Because the practitioner that works with us works on the other systems first. If you're only dealing with hormones, you're going to see a biased prescriptions of 10 milligrams per day. You're going to have this protocols of giving those very high dosages of all the hormones all day long. It is not necessary. Okay, so fix every single thing and strive to achieve proper endocrine balance for your patients, for them to feel better. And the balance is something that you cannot measure. I'm sorry, Mark, you cannot measure balance, but you can feel a balance. You can test to get into balance, but you cannot test for balance, right? So it's just one of those things, and we want to make sure that we feel the proper balance. I still believe that we ought to mimic natural cycle as much as possible, as long as we can do it, and the patients are willing to do it. Now, initially, when you see the patients, you want to give them continuous hormones, but after the first 3 months, start giving them some hormone-free period. Okay? I just told you right now, you don't remember any of those things, because guess what? Whatever I told you right now, I guarantee you're going to forget by tomorrow. I'm sorry. I've been doing it for 20 years. I know what is going to happen. You're going to forget this by tomorrow. That's another reason why you work with a compounding pharmacy, because we do this all the time. We have 10 pharmacists. That's all we do is we get a call from the doctor, say, hey, patient has this problem. What do I prescribe? And it's now they don't call us for all the basic questions, but they call us for the tough questions. But if you're starting off, we don't mind helping basic patients first and then helping the tough cases later on. So just keep in mind the information is there. Use it the best you can, and just talk to your patients. That's all I can say. Thank you very much for this evening.